everyone, and welcome to another H3 Humanities at the Heart of Healthcare webinar. My name is Aaron Ang. I'm Director of Humanistic Medicine Institute, HUME, at NHG Health, and it's my privilege to be your host and moderator this morning. Today's webinar is jointly organized by HUME and Hui Ling's office, the NHG Health Value Office, and we are delighted that you have chosen to spend this hour with us. Let's begin with a question. Have you ever walked away from a patient interaction having completed every form, met every KPI, achieved every quality indicator, and yet wondered whether you truly cared for the patient? Based on the questions submitted by our participants, I suspect that many of us have. Healthcare has never measured more than it does today. We measure safety, quality, productivity, cost, outcomes, and patient experiences. As some have observed, Moneyball has come to healthcare. Don't get me wrong, these measures have transformed healthcare for the better, and I can attest to this as I've been practicing for the past 30 years. But healthcare is not baseball or soccer. Our purpose cannot simply be to optimize performance. It has to relieve suffering, improve lives, and care for the people. Measures is essential, but only when it remains anchored in that purpose. As we embark in Singapore on our PROMs, patient-reported outcome measures, and subsequently patient-reported experience measures, we must ask, how do we ensure that these measures remain faithful to what matters most to patients rather than become another target for optimization? Charles Goodwin, an economist, offered a timely warning. When a measure becomes a target, it ceases to be a good measure, and that is what we want to discuss today. Waiting times can become more important than waiting patients. Documentation can become more important than conversations. Patient experiences can become just another score to improve rather than another story to be understood. So today is not about whether we should measure. We absolutely should measure. The question is whether our measures still help us see that the people that they were designed to serve. Now, before we begin, let me just say a few words about what I'm hoping or what we're hoping to achieve at the HUME webinars. At HUME, a central pillar for all our learning activities is not to be didactic, but really dialogic. And therefore, today's conversation is actually very good. Not when we don't want to be instructional, but also to promote reflection. Therefore, our goal is never to hand you another checklist, an algorithm, or protocol. We cannot offer neat answers to the complex and often messy questions that healthcare professionals face every day. Instead, H3 creates a space to pause amidst the busyness of clinical work. So take a time off to reflect on this 1 hour. It's a precious time to examine familiar problems from a different perspective and to reflect on how our professional values are translated into the realities of practice. Where trade-offs are inevitable, values often conflict, time is limited, and there is rarely a single right answer. If you leave today's webinar with a few new questions, a little intellectual discomfort, and perhaps a renewed sense of curiosity and inspiration, then we would have considered that the time you spend with us well spent. Because wisdom rarely emerges from certainty, it grows through thoughtful dialogue, honest reflections, and professional humility that keeps us asking what truly matters. Now, before I introduce the speakers, just a few points for housekeeping. This format is about 50-minute conversation with our 3 panelists, and then if we have time, a 10-minute Q&A at the end. We love this to be a conversation with the participants, so please post your questions into the chat group. We'll try to incorporate it into the discussion, but if we can't, we endeavor to respond to it after the webinar. At the end of the session, we would value your feedback. We want to continually improve. And if you are interested in our HUME activities, sign up for our mailing list. Now, it's my pleasure to introduce our speakers. We could not have asked for better panelists to explore these questions. We are especially honored to welcome Dr. Dina Safran, one of the world's leading voices in healthcare quality and value-based care. Dr. Safran has spent decades shaping how health systems understand, measures, and improve what truly matters to patients. As Singapore continues on this journey, or we are just starting on this journey, we are privileged to learn from her international experience and thoughtful leadership. Thank you, Dr. Safran. Joining her is my friend, Professor Tan Hui Ling. NHG Health Group Chief Value Officer, who will share how these ideas are being translated into strategy, culture, and implementation across our healthcare system. A quick word about Hui Ling. I think her office should be Chief Values Officer, because if you think about how she has conducted the way in which she has promoted quality, it is quite inspirational. Lastly, we complete a panel with Dr. Tiu Chi Wee, Senior Consultant Geriatrician at Khoo Teck Puat Hospital and a member of the National PROMs Work Group. Her experience across acute, community, and transitional care brings the indispensable perspective of a practicing clinician over the various theaters of operations in healthcare and how patient-reported outcomes can enrich rather than burden everyday care. So together, they will help us explore healthcare and how measurements is not just a task to be performed, but actually relationship to be cultivated. So let's begin. I will start with a quote. Looking back, our value-based healthcare succeeds only when it reflects what matters to patients, not merely what is convenient for healthcare systems to measure. Dr. Safran, I think you mentioned that, or I'm paraphrasing you. So looking back at your career, I mean, how have you come to this point in your career and are convinced that we need to move in this direction in terms of measuring healthcare? I hand the floor over to you.
Oh, thank you so much, Aaron, and thank you for the warm and great, generous introduction. I'm really honored to be here. This is close to the end of my 2 weeks in Singapore, and I'll start by saying I have been so impressed at how much progress the clusters have made in 3 years' time since I was here in May of 2023, at really transitioning to a population health perspective. And so to really answer your question about, you know, the journey of my career and how I find myself here, I began my career actually in research setting and expert in the measurement of patient-reported measures. I was sitting alongside the individual who is credited with being the father of PROMs, and I myself was a developer of measures that you might today call PREMs, though we didn't have that nomenclature at the time. In particular, of interest to Hume, I was focused on measuring the quality of clinical relationships and how the quality of clinical relationships, things like how much a patient trusts the clinician or care team, how much they feel that care is oriented toward them as a whole person, and communication quality, interpersonal treatment, how those things were shaped by the organizational characteristics and how those attributes of the clinical interaction shaped outcomes of care, health outcomes for the patient, business outcomes for the provider. And I moved then about 15 years time to applying measures, to a role first at Blue Cross Blue Shield Massachusetts, where I was one of the architects of a payment model that really catalyzed the field of value-based payment, because we were combining quality measurement, including patient experience, with cost accountability and care for the population across the whole continuum from prenatal care to end-of-life care. So that probably sounds very familiar to the payment model and accountabilities that the clusters have today. And that's not a coincidence. And so to then come to how I see that arc of my career, you know, in the very early days, I would say that clinicians and health systems didn't even really accept the idea that patient-reported measures had any value. In terms of PROMs, they thought, you know, what is it a patient can tell me about their health that I can't know better by doing, you know, a physical exam, listening with my stethoscope, doing an X-ray. And in terms of PREMs, they regarded it with a lot of disdain as merely an indication of, you know, satisfaction, but not capturing anything that constituted real information. And here we are 30 some years later, where both PROMs and PREMs have taken center stage as we really move from what I've called building-centered care to patient-centered care. And as we have moved toward care models that give providers accountability for cost and quality and outcomes, we've seen providers begin to realize that they have to consider the patient as a whole human being, not just what happens in the context of the four walls of the clinical setting, but what are the barriers this specific individual will face as they try to implement the instructions and guidance they've been given by their clinicians. So in fact, the patient experience I refer to as the bridge that links us from clinical advice to good patient outcomes. And we very much have to care about the experience of that patient because it is that experience that will influence how openly they share the information we need in order to guide them, and how well we understand the adaptations we need to offer in order for them to leave and be successful in managing their chronic condition or undertaking prevention. So I hope that is a good and thorough answer to your really important question.
It looks like you're a bit clairvoyant in the ability to see what's important in the future, and we are moving in that direction. Indeed, Hume is actually quite interested in it. I hear you keep saying whole person-oriented care. And it's one of our pillars in that we want a healthcare worker to look beyond the biomedical. Now I turn to Hui-Ling. Dr. Safran has shared her journey. I have spoken to you informally, and there's a lot of stories in which you want to tell in how you had also come to this point. Maybe I hand the floor over to you.
Yeah, thanks, Aaron, and thanks, Dana. I think that along the way, when healthcare becomes, so technical and so complex and full of numbers, we all have our aha moments about when we realize that the patient matters more than the KPI or than the measure. I was the ICU director and chair of the ICU committee for many, many years. And in the early days, we were very short of ICU beds. So we were constantly looking at the ICU length of stay. And then we started looking at the long stayers. And we were making hardly any progress. And then came Mr. Au. Mr. Au slipped one morning in the corridor of his apartment block and sustained a high cervical cord injury, and he was paralyzed from waist down. So he literally went off the charts in terms of length of stay. He had a tracheostomy, he was on a breathing machine. We could just send him out on a scaled down breathing machine to the general ward, but that wasn't good care. We tried, and then he bounced back, and we learned that wasn't good care. So to cut a long story short, when we started to focus on the patient and not the measure, we started asking what were his needs. And out of that actually grew the home ventilation program that now serves the entire country. So that was a true lesson about listening to the patient and being very patient-centered in the care and be less bothered by the measure, although we knew that next month our length of stay is going to bust the charts.
Thanks, Hui-Ling. The home vent service is really awesome in the sense that it is very inspiring, but it's also very frightening to realize that you can actually push yourself to that level. Now, I turn to Chi Hui. You have cared for older persons across the whole theater of care, from hospital, transition care, telehealth, nursing homes, community, dementia, so on and so forth. Then it gives you really a unique perspective. Share with the rest of us, from your personal experience, what convinced you that traditional measures itself was not enough.
Thank you for having me here this morning. Yes, in a way, I've come a full circle in my career. I started from the hospital, moved into transitional care, supporting patients from the hospital to home, aging in place. Then I became a geriatrician, as a resident geriatrician in a nursing home. And now I'm back into the hospitals, working in the wards as well as our network of Caritas dementia services. Now, this journey has actually taught me one very simple thing, that the only constant in this whole care journey is the patient themselves. Now, as the patient move along this continuum, the setting change, the teams change, Even the goals of care may change, but what remains constant is always that patient. And if we want continuity, we have to look to the patient for that information. Their values, their priorities always travel with them. So for me, this information of what the patient can tell me, what they think is important, has always been the core foundation of my care as a geriatrician, because it always guides us in tailoring what we call person-centered care for them, and it always works regardless of the settings I see them. I just think that listening to the patients always works, even in very complex patients.
Thank you so much in terms of sharing this issue. I think Dr. Safran has also mentioned the continuity of care, the whole person care is actually a very simple but not easy way of actually improving care. I transit over to the next question, the next part of our sort of a dialogue, where we want to look at the measures themselves. And here is very interesting, where we actually get questions even before the webinar. So there are some questions that have come in. We have become extraordinarily good at measuring health care, but are we actually good at measuring health? So the questions that have come in are like, how do you measure outcomes that matter to patients beyond clinical outcomes? How do we go about converting genuine patient outcomes and experiences into robust, measurable indicators that accurately reflect the effectiveness of the program? How do quality surveys, how to quantify qualitative surveys to measure improvement, especially things like family feedback? And if the patients are filling up the PREMs or the PROMs out of goodwill, how can they see the feedback being acted on? So the themes that surround this is really the fundamental tension of, can we convert these measures into genuinely things that will matter to patients? Dr. Safran, you often describe your career in two halves, which you did mention. The first half developing measures, and the later half leading teams to actually improve healthcare. So looking back, and looking at the questions, how did the second half inform the first half, and can we sort of cycle out of that?
Yeah, I think that we started to talk about this before, in that, in the second half, as we began to create measure sets and use measures in ways that went beyond academic studies of the 1990s and the early 2000s to the real world high stakes use of payment models and public reporting of performance and steering patients based on performance. This is where measurement at first was seen with enormous promise, but the measures that we had to work with were really very process focused and ultimately came to be resented by clinicians, because clinicians felt that the measures were kind of reducing them to just checking boxes and not really using clinical judgment. And what's more, when you're evaluating care based on process measures, you often need quite a lot of measures. And so some of what I think is so appealing about a value-based payment model and how it transforms the measures that we need, it allows us to remove the accountability for the process measures and set accountability for what I've called big dot measures, the outcomes that matter, including the highest big dot, which is, have we actually helped the patient to feel better and function better? And that's where PROMs come in. With that, I would say we can be quite parsimonious with the measures in our portfolio of accountability measure sets. And that's not to say that those who are providing care might not still want to have a set of process measures that they're looking at that help them understand how the levers they have to help achieve those outcomes. One of those, I would say, I would not want us to think that all we need are those patient-reported measures, the PREMs and the PROMs, because, for example, if we think about a patient with diabetes, and if we only factored in what the patient said was important to them today or in the next few months, we might not be focusing on good control of hemoglobin A1C and blood pressure, cholesterol. but we know we need to control those things for the long term. So I like to provide that caveat that we need that blend of the clinical outcome measures, the clinical metrics of what are the indicators that a condition is under good control, or that we are doing what's needed to prevent the onset of a condition, together with the patient-reported measures, or maybe as drivers of the long-term results that we're trying to get with those patient-reported measures.
I think those process measures are indeed important. I mean, we can't run away from that because that's our professional duty. I guess the challenge is that if it's just that, it sounds rather transactional, and that's where the doctors feel that it could be actually more. We should not just be focusing purely on the transactional nature, but really on the relational nature. Having said that, with AI and technology, the process measures may be easier to be measured, and then we are allowed to focus on actually the relational or the matters that are important. Now, hearing what Dr. Safran had mentioned, I hear you nodding away. Maybe you want to respond. How has NHG and how has your office actually embraced these ideas?
I think that if we want to improve, we really need to have a deeper understanding of measures and have a healthy relationship with measures. So talking about measures, increasingly, we are rolling out courses and during meetings and at management meetings when leadership asks questions and when we do leadership reporting, we really do need to inculcate a culture where the data is factual and it's the interpretation that matters. And leaders need to learn how not to take one measure, like a ruler, and then everything becomes a 2x2 square. So I think it really relates to me that we need to look at, in the traditional quality science, we look at outcome measures, process measures. And for today, because there's so much complexity, we need to look at balance measures as well. If we do A, like if we reduce length of stay, what might happen to readmissions? Might the problem be hidden and tucked away somewhere else that we're not aware of? Yeah.
Like I mentioned in the beginning, healthcare is not simple. It's actually very complex, and invariably you have to make trade-offs. And that's where the measures, the various measures may make you make the best decision in terms of what trade-offs you want to make. Having said that, from the clinician on the ground, Chi Hui, can you give examples of PROMs or PROMs that you have been working with that helps you enliven or articulate the discussions that have been going on so far?
Yes, I do also totally agree that clinical outcomes must still be part of the picture, and that's very important, and that's our duty. But there are also many instances where a good traditional clinical outcome in one setting may not always be very meaningful in another setting. And I will cite an example that many of us can recognize, are familiar with. An elderly patient is admitted for pneumonia. We treat him with antibiotics. He becomes afebrile, wean off oxygen. We call them vital signs stable, white cell normalized, and we say that he's fit for hope. Clinically, by every measure, he is fit for hope. And yet, the patient will ask us, how can I go home like this? And it is true, clinically, he has recovered, but from his perspective, he's really not fit for hope. He may feel very anxious, feel unsafe. He may be very deconditioned and knows that he actually cannot manage when he goes home. So for him, it is not whether my infection is treated alone that's important. He also wants to know, can I still continue to function and live in a way that's meaningful to me when I go home? And that's the problem. And that's in such cases, and I think this is in such cases where the PROMs are useful. Asking our patient about their functional status, asking them about their psycho-emotional well-being can help us identify any gaps before we send this patient home into an environment that maybe he's really not ready to be in. Yep. And I think that's why I think PROMs has always been a very useful part of our geriatric practice.
I think the healthcare is moving from acute episodic care. If you are going to talk about chronic longitudinal care, then it cannot just be a measure of clinical outcomes. And that's where the PROMs and possibly PREMs comes in, because we are increasingly aware of the psychosocial determinants of health. And that comes in when you're talking about chronic illness. Now, moving on to the next part, I wanted to just ask about, can PREMs and PROMs escape Goodhart's law? In other words, not just be a target and we chase it. Again, Singaporeans are very good at hacking the system. We have hacked how to do GCE, O-levels, A-levels, how to hack to get into medical school. We have lessons on how tuition on how to do that. We are very adept at that. But again, moving away from that, we want the heart and not just the head to do it. So PROMs and PREMs feel really revolutionary for Singaporeans. But they also create a new danger, which I mentioned before. Once measured, will they just become targets? How do we prevent PROMs and subsequently PREMs from just becoming another KPI that we tick off, that we say, no, we have done, and so on and so forth? So there's some questions that actually come in with regards to this. Without clear targets, what mechanisms will drive continuous improvements and measure consistent standards across institutions? And in situations where focusing on PROMs and again, this will come back as another theme. Monetary value may compromise PREMs. How do we navigate this? How do we navigate not letting it just be a more outcome that we game or we hack? Dr. Safran, to you, you have seen best practices. You have seen organizations that may have done it well, and you have seen organizations that have not done it well. And therefore, to the eager Singaporean to want to know how to hack the system, maybe your wisdom in seeing what best practices and how we can actually transcend that from your global perspective becomes crucial for us in Singapore. What do you say?
Thank you. So what I'm going to say about this is not specific only to PROMs and PREMs, though it definitely applies there too. And that is that we have to remember, as we use measures in high stakes ways, meaning people's reputations are on the line, people's finances are on the line, that we first have to gain the understanding from those who will be measured, whether that's clinicians or organizations, and their belief that the measure is fair, that it is accurate, that it is measuring something important that they care about. Because if those conditions aren't met, then that's where gaming happens. If I believe that what you're holding me accountable for just isn't something that's fair to hold me accountable for, or that the data you're using are not really a reflection of the care that I'm providing, then I would just rather take shortcuts and game the measure than actually perform on the measure. So I like your notion of, winning the hearts, but I wanted to paint that picture of what does that actually mean? That, I think we can believe that every clinician starts their day wanting to do the best for their patients, but they also have self-interest. And so we have to be sure that in the pursuit of doing the best for their patients, that they see the measures that we're using as a tool for that, not as an impediment or a frustration in their day. And so how that pertains to PROMs and PREMs, I think that in many ways, we're at the very beginnings, PROMs, maybe less so with PREMs, but with PROMs at the very beginnings of clinicians understanding what are these measures, what do the numbers mean, and what is it that's in my power to move this score, right? I've long been familiar with a hemoglobin A1C number or a blood pressure number, and I understand what it means to what's good, what's bad, and what tools do I have to move it. But I may not understand when a patient has a PHQ-9 score of 17, is that good or bad? And if it's bad, which it is, what is it that I can do to help make it better? Who can I refer to? What tools can I use? And so long before we create accountability on that measure, meaning my scores are going to be shown to others, or I'm going to have some financial stake in my performance, you have to help me begin to understand this measure, believe the measure is fair and correct, and know how can I improve my performance on this measure. So I believe that's just really a critical best practice, is to gain that buy-in before you begin to use measures in any of the high stakes ways.
It sounds like it's a culture change. It's a change in the culture, and obviously cultures don't change overnight. But I guess another aspect of it from the education lens, we want it to be as much a formative sort of measure, educational measure, before you want to say it's a summative measure. So they need to be able to pass the smaller tests in what they want to do to develop the ability before you say it's a high stakes type of test. Now, Hui-Ling, over to you. In response to what Dr. Safran had mentioned, how do you think, we are certainly early in our journey, but how do you think that we can actually use this as learning tools rather than just straight up performance indicators? Some thoughts on your part?
I think that Singaporeans are very good at asking what's the right answer. Okay, what's the score I should achieve? Okay, that's just part of our DNA, right? Because we've been graded and we've been banned since
Primary school, yeah.
primary school, yeah. So I think one of the important things in healthcare today is, firstly, from a leadership standpoint, to resist from setting a target. So this relates really, really back to Goodhart's law, right? Because at this moment, we don't even understand the complexity. We don't understand the measures, what we're measuring, what the measure is telling us, what the measure is not telling us, and then we go set target. Okay, so on what basis are we setting the target? Okay, my personal pet peeve will be when I hear at meetings people say, okay, how about we look for a 10% improvement upon last year? And like, hang on a minute, we're talking about biological systems here, right? We're looking at infection rates. What does reducing by 10% mean? When we've been looking at MRSA bacteremia rates, and sadly, we belong to the not so good side of the data, and we've been thinking, what does an MRSA rate of, say, 1.5 per 10,000 patient days, what does that mean? And I kind of like to put it back to say, hang on a minute, this is not about a rate. It's people we're talking about here, right? So with this rate, how many patients actually suffered from MRSA bacteremia, and what happens to them? Well, what is the human suffering behind this, and what are we going to do about it? What can we do about it?
Thanks, Hui-Ling, for mentioning that. I'll ask maybe Chi Hui, do you want to comment? Are you persuaded? I mean, you are obviously persuaded because you're doing PREMs and PROMs, but how do we actually persuade or based on your clinical experience, demonstrate that the PROMs are actually useful and that you see the difference when you're practicing on the ground with it?
Honestly, I think if you ask the frontline clinicians now at this moment, many of us are not very clear what's the purpose of PROMs and PREMs for, and it can sometimes feel like it's just another field to fill in, and therefore we see it as, well, many of us see it as being burdensome rather than something that's valuable, and it is not wrong for them to think of it that way, because we haven't understood what PROMs and PREMs is about. Sometimes to us, at least at this moment, PROMs to some clinics can be collecting the information. It can just mean filling up a column in our Epic flow sheet in our context, and once it gets filled in, that's the end of it. And then that conveys a message to our ground staff that I'm just collecting the numbers. For us, what we use the PROM is that we actually look at the PROM and then use it as a conversation starter. We say that, looking at the PROMs, looking at your mobility score today, it seems to have dropped compared to the last visit. Can you tell me what has changed? And that's when we can start understanding what has changed. And it is a much faster way of getting to the problems, to be honest. We can also ask, looking at your geriatric depression scale score, it is high. Can you, which means that you may be feeling depressed or anxious. Can you tell me more about it? And then from there, we can listen more to the patient and understand more. So I think that's how we use PROMs. So I think for the audience, I think if we ask the patients these questions, this PROMs question, and then we stop there, we don't do anything, then that's just collecting it. That's not very useful. But if we look at it, we use it to ask patient more, to listen more, and change what we do subsequently, then it becomes a very powerful tool. Yeah.
So it sounds like it's a tool for listening and for adapting and then for improving, because patients are not exactly one and the same, and it's for us to actually improve our practice. Feeling you mentioned about 10% improvement and the frustration you have in such meetings. I mean, there's a question that has come in like that. Cost savings, and I mentioned about money before that. Cost savings often still is the goal or strong outcome to prove or justify for sustainable or scaling the program. And how do we move away from money talks to PREM and PROMs that we can convince senior management? I was in a meeting with a senior CEO of a private entity, and he was mentioning my boss's target for me is a 15% profit year on year. I can't think if that is the mindset, then if you turn it into the public sector, it will be a 15% austerity for the public sector. So I guess that the audience is also not asking, how do we transcend Goodhart's law by actually not making it just a measure, but also how do we transcend this austerity sort of narrative in the public healthcare? Any comments on this at all, Dr. Safran?
Yes.
How do we move
Yes.
away from this austerity? It is a 10% cut, no matter what, 10% cut. And I think you have mentioned we can just say we just don't offer some services and then we make a profit from that. Maybe you can speak to that. You can speak to that as well.
Yeah, I would love to speak to that, but just before I do, I want to underscore, I was so excited to hear what Chiwei was describing as their way of engaging with PROMs, because that is the gold standard, right? It is not only the way of bringing real joy and meaning to the clinician, because it's allowing them to see how the interventions they are making, the changes in the medication, the procedure they did, how is that actually affecting how the patient is feeling and how they're functioning? It also allows the patient to see that answering those questions matters. It makes for a better encounter. And so in my experience, back to your question of how we get these kinds of measures accepted in clinical practice and not seen as a burden, what Chiwei described is exactly how we do that. Because once you're doing that, the clinicians will say to you, I never want to practice without these tools ever again. They are so valuable to me. So I wanted to just say that. Now to the money piece, I was speaking about this just yesterday, and here's what I suggest, and I'll put it out there, but I really want your hard feedback. And if you think this is, absurd, then I want you to say so honestly. In my view, I think we say this, that the idea of value-based care is the idea of how can we achieve the best possible outcomes for an overall cost of healthcare in the country that we can sustain. And so where does quality and safety fit in with value? Well, it's at the heart, right? So quality, to use the Institute of Medicine framing from 2000, is care that is safe, timely, effective, efficient, equitable, and patient-centered. Those 6 pillars tell us how high quality. Quality is needed to produce the outcomes we want to achieve, and value is the outcomes we're achieving for the cost we're putting into it. And the reason we have to think about cost is not that we're trying to skimp on any service that any individual patient will receive, because we have our eye on the prize. We have our eye on achieving the best outcomes for the patient. But why do we have to think about cost? We have to think about the overall cost of healthcare to our country, because healthcare costs are growing faster than the rest of the economy. And if we allow that to continue, then we have to take away from other areas. We have to spend less on education or housing or public safety or public health. And so that's why we have to address the overall cost that we're spending for healthcare and keep it in line with the rest of the economy. And so that's where the value equation comes in. So I hope that's a helpful construct from your perspective, but I welcome you to knock it over and say that it's still not going to help the public understand what we're doing.
Hui Ling, any comments,
Yeah,
any
perhaps.
reflections based on the discussion? Again, this is a nicely contested view, but that's what we enjoy at Hume. We want different voices such that we can be reflective in our opinions.
Perhaps I will add on to that. Some time ago, when I was reading around this, there was this statement in an editorial from a physician that struck a chord with me. It says that value stems from the end of the physician's pen. And that made me think through what we do every day. So rather than, getting frustrated or disgruntled with administrators' talk to cut 10%, I think it's a call for reflection. When I go to the ICU, when I give an anesthetic, what makes me choose drug A versus drug B? Do I even know what drug A costs and what drug B costs and the effect that they have on the patient? So it's kind of made me think that once we understand that we can no longer afford to spend in healthcare the way we have been in the last couple of decades, then I think the best people to know how to spend each dollar wisely are firstly the patients, because they know what matters to them. And next to that is actually the providers, doctors, nurses, allied health, because we know that if we only had $1, where will we put that $1 on to get the best that matters to the patient? So I think that the true success factor here are the providers.
Chi Hui, any comments at all? You being on the ground, you are the one with the pen. Any comments?
I guess nowadays is the keyboard, isn't it?
Yes.
But while we use PROM, and I think it's useful, we are generally uncertain and concerned if we want to talk about tying PROMs to certain money and financing and resources. Because one of the questions that all of us always have is that if we tie PROMs to funding, for example, then what happens to patients whose function will decline no matter how good the care is, simply because of their disease trajectory? Many of our patients, dementia, advanced illnesses, they can decline, and decline is the expected and honest outcome, even if our best care. So if we are not careful with using these PROMs as a target, then it can make excellent care look even as like poor performance, non-cost effective care. And then that $1 that Prof. Ling is saying, right, may end up not being given to this patient who really need that $1. So the question that I always have is, how do we measure success then in this population where even their PROMs can be expected to decline with time?
I guess the challenge is the measures can be at the healthcare institution organization level, it can be at the department level, and then it can be at the individual level. So again, as a guard to not say one size fits all, a psychiatrist's outcomes is the same as a geriatrician, is the same as an anesthetist. And that's where I think we need to have some skin in the game to actually guide the type of measures that we want and not just acquiesce it to whatever you pass on to me. And I think this speaks to the culture building. The culture shouldn't be top down, but also bottom up. We are, in the interest of time, I'll move on to quickly the next section, which is particularly interesting to me about future measures and things like PREMs. There are two questions that have come in with this. Singapore's communitarian culture or Asian culture or communitarian one does not always map nicely onto individual choices where families sometimes make decisions and so on and so forth. That is baked into some of the PROMs and the PREMs. So would a sort of merit-based incentive payment system, reward evidence-based practice be a better leveler for value-based care here? Again, I'm just reading out the words. I'm not fully appreciating what it is, but it sounds as if can we do measures that are more culturally appropriate? And then, of course, how do we leverage on PREMs, and how do you leverage on electronic medical records and so on and forth to actually then motivate, sort of push this forward? So the theme is really whether it's culture and system fit for such context. So gazing into the crystal ball, what do you guys think is the measures that we want to head towards subsequently? And if we were able to redesign healthcare today, and which we are trying to do in Singapore, what would you measure? So Dr. Safran, early in your exploration, and you did mention this, right? You were looking at the relational dimensions of care, and that's where I guess PREMs actually came about. Many people know you today as the world leader, expert in value-based, but you did mention this, that you were actually working on the quality of doctor-patient relationship. So looking forward, do you see a role to measure relationships, trust, continuity of care, rather than patient experience, meaning satisfaction or in terms of the PREMs? Do you think that the measuring the relationship can be better than a transactional sort of measure?
Yeah, I do. And, I think that what I see as possible is that we are at a very exciting moment, but we're also at a moment, a perilous moment. And what I mean by that is we understand that right now, the pressures of the clinical setting have made it harder and harder to give real time and whole person attention to patients. Clinicians feel terribly rushed. Technology can get in the way. The electronic health record and the requirements for documentation can literally take our eye off the patient and have our eye on a screen. And the reason I say that I'm hopeful in this moment is that if we are really purposeful in the ways that we adopt technology, including AI, I believe that we can begin to reduce some of the burden on clinicians and allow them to quite literally have their eye on the patient again. So take, for example, ambient listening, which really, at least in the US, is providing great relief to clinicians, right? And in the clinical encounter, allowing them to fully focus on the patient. This means we can ultimately have our cake and eat it too, right? We can create a very rich clinical note and have very rich ways to use the data in the clinical record for measurement, even while allowing the clinical encounter to be one where those who are providing care and those who are receiving it are engaging eye to eye and human being to human being. And I think that gives us the capabilities, but also we need for Hume and the types of enlightened clinicians I've been listening to in this webinar for the last hour to really bring forward this idea that the quality of the interaction is one of the very best tools we have for ensuring that we get to good outcomes. Not just that we have a patient who walks away feeling that, they received great care, but actually that they were comfortable to share with us the things that feel vulnerable that actually we need to know in order to give them good guidance. And for us to understand and ask about their real world constraints so that we can help address them and achieve those good outcomes. That, like we said before, that experience is actually the bridge to achieving good outcomes for the patient. And so I am optimistic that enterprises like Hume can really help to elevate patient experience as something that is not at all about just, is the patient satisfied, but does the patient feel supported, understood, and therefore able to share information, receive information, and leave empowered to do what's needed for their care.
There is this very interesting book by Alison Pugh that talks about the last human job, and it turns it inwards to suggest that relationship is not only good for the patient, but it's also good for the provider. You actually feel good when you actually care for the patient and not have to do all this and that and the other that takes away from the relational aspects. So if we do it well, it's not only helping the patient, potentially it is helping us to be better clinicians. Hui Ling, what do you think? 20 years down the road, we'll most probably be retired by then. But what do you see healthcare for our juniors and our residents like in 20 years' time?
I see promise for them because, you know, as we interact with them on a day-to-day basis, we just see how clever they are, right? So I think as seniors, we just hope that we create the conditions that allow them to think better so that they can solve the problems in future better. I want to pick out this point that Dana used, which I think is something that we all need to be very mindful of, is the word peril. Okay, with opportunity comes peril, and we have two great perils now. Okay, one peril is we have so many numbers, but we're not sure whether these numbers add together to form true insights that should lead to action. Okay. And then on the other note, with so much demand by regulations, by various accreditation standards for documentation, the easy solution is to design another smart phrase in Epic. In the old days, it used to be, we need another form, you know. And with so much documentation, right, we are getting lost in note bloat. It's like, where is the pertinent information? So I think if we kind of hold these two tensions as we climb this current mountain that healthcare has to climb, I'm optimistic that our juniors will hold through to the ethos of healthcare being about caring for people and get through the top.
Feeling guilty as charged. I just asked for a smart phrase yesterday because they were saying we failed some quality indicators. So can we please come up with a smart phrase? So guilty as charged. It's difficult to cycle out when you are so inundated, and so this information bloat is a true issue. Chee Hui, anything to add?
I agree that, I mean, these are some of the implementation work processes problems, but nonetheless, I'm actually very excited. I'm excited that we can now are looking at measuring these relational dimensions of our care. Because for the past 10 years, we, at least in KTPH, we've been practicing what we call humanitude as a relational care approach for our vulnerable elderly. We focus on strengthening these care providers and patient relationship. We have to seek their autonomy to enter their space. We establish that perceptual connectivity, and we even make a conscious intention of making an appointment for that next encounter to build that trust and that continuity. And in our experience, it has been associated with better outcome, focusing on this relationship building. Patients have less agitation. There is less restraint rates. In fact, we've been able to maintain a restraint-free environment across all our geriatric wards, and it is really a big part of it. But the questions that goes behind my mind then is that beyond this observed distress, agitation, restraint rate, I would really very much want to know how is the patient's own experience of this relationship. How do they feel? Do they feel safe? Do they feel respected? Even for our patient with dementia who may not be able to report, then how do we measure it? Because I think it's very important if we can measure this relational dimension of care, then we can understand what works, what matters most, and we can continue to improve. So I think this measure is something that's measuring this experience is something that I really look forward to, and I hope to learn a lot more. Yeah, thank you.
I know time is quickly catching up with us. I had a quick look at the chat to see what questions came about, and they seem very coherent to what we have been discussing before. So someone asked, KPI currently implement, are you considering actually eliminating some of these proxy measures? Dr. Safran, I've heard you say maybe when one is implemented, two should be taken away. whether we are conscious about how we are implementing it. Again, a lot of frustration about measure, then what is going to come out, and there's some even say, how do we catch the cheaters, the people that game the system? I mean, my personal thing is that the system structures it in such a way that you are forced to cheat rather than, because as I think Dr. Safran mentioned, no one comes into healthcare to want to cheat. nobody comes in that way. So again, I think from the questions that have come in, we did sort of answer most of the questions that have come in through the chat. The only last one is there's someone that's asking for your prompts, Chiwi. So maybe at the end of the day, you have convinced this person to actually adopt some of the prompts that you have.
So,
I'll look at the chat and I'll send it to you later. Now, I'll just, in the last 5 minutes, we'll just have a quick fire sort of round in a simple, complete this sentence, and I'll go around the room, first with Dr. Safran, then with Hui-Ling, then with Chi-Hui. Healthcare becomes more humane when ... So in one sentence, when does healthcare become more humane? Any thoughts at all? You need not go in that direction. Hui-Ling, you can go first if you thought about it. Chi-Hui, you can go second. It doesn't matter, but in the last 2 or 3 minutes, maybe you can just quickly mention how do we see healthcare becoming more humane?
Okay, I'll go first. Because this is very personal to me. Healthcare becomes more humane when a smile from the patient and a thumbs up means more than all the KPIs in the world. Yesterday, I was with a patient who was anxious. She was having her eyelids done. And at the end of it, I asked her how she was. She gave me a thumbs up. That made my day.
Chi-Hui, anything before we leave the last word to Dr. Safran?
sure. I think we're going back to what we have always been taught as medical students, right? Healthcare, it becomes more humane if we start with listening to the patient history and we end with listening to the patient's verdict of how well we've done.
Nice. Sorry to put you on the spot, Dr. Safran, but you have
Yeah.
the final, you really have the final word now.
Yeah, I don't think I can do better than those two, but I'll try to say the same thing with some slightly different words. Healthcare becomes more humane when our metrics and our care models truly keep the patient at the center of our focus, and that allows for the joy of clinical practice to also return to those who are providing care.
Thank you so much. With that, I would bring the webinar to a close. But before we close, I would like to go through certain housekeeping things that we need to do. First and foremost, thank both Dr. Safran, Dr. Safran, Hui-Ling, Chi-Hui for the thoughtful and inspiring and insightful sharing and reflection. Again, I think more question than answer, but if you leave with some level of inspiration, then we have done our job. Thanks for the participants to be engaging in our webinar. The numbers haven't dropped. I've kept track, and they have kept at about 300 to almost 400. So thank you so much for being engaged with our webinar. A reminder, we have another MME accredited webinar at lunchtime, so do join us. The last thing is, of course, to just give feedback to us on how we did with regards to webinar and whether you're interested in our future programs. The QR code will come on after we all go off. So without further ado, just at the stroke of 9, thank you so much, Dr. Dana, Hui-Ling, Chi-Hui, and I hope you have a good day ahead. Thank you so much.
Thanks, Aaron. Thanks to Hume
Thank you,
for
everyone.
facilitating this.
Thank you so much.
No problem. Take care.
Thank you.
Bye.